Hello and welcome to the Hospice Education Podcast. Today we're going to be focusing on skin integrity and pressure ulcer identification, an area that underpins safe, compassionate and person-centred care. Today I'm joined by Tracey, clinical trainer with Hospice Education, who has 27 years of experience in palliative and end-of-life care. Thanks for joining us, Tracey.
Thanks, Leanne, and thank you for having me. This is such an important topic and one that I'm really passionate about. Skin integrity is often something that we only notice when it starts to deteriorate, yet really it's central to comfort, dignity and quality of life.
Okay, so let's begin with when we talk about skin integrity, what are we really referring to in practice?
Yeah, well, really, at its simplest, we're talking about skin that's intact, healthy, and actually functioning as a protective barrier. But in practice, skin integrity also reflects overall health. Changes in skin can really tell us a lot about hydration, nutrition, circulation, and mobility within an individual.
And pressure ulcers can have a significant impact, can't they?
Oh, absolutely. They're really painful, they can affect dignity, and they can cause a great deal of distress. In severe cases, they can lead to infection, sepsis, and actually even death. For people approaching the end of life, pressure damage can significantly affect comfort and quality of remaining life.
And despite guidance and prevention strategies, pressure ulcers remain common. Why do you think that is?
Well, it often reflects the complexity of the people that we're actually caring for rather than a lack of care. Increasing frailty, multiple long-term conditions, reduced mobility, and acute deterioration all increase risk, sometimes very quickly.
Okay, so let's move on to, recognizing healthy skin. What should staff be looking out for?
Yeah, well, really, healthy skin, it should be intact. We want it to be warm, but not too hot, well hydrated, flexible, and free from inflammation, swelling, or visible damage. Also, it shouldn't be excessively dry, flaky, or overly moist.
So hydration and moisture both seem to be really key themes here.
Yeah, they really are. Poor hydration leads to fragile skin that tears easily, while excess moisture, particularly from incontinence, can actually weaken the skin structure and increases vulnerability to breakdown. Both ends of that spectrum can really cause problems.
Okay, so in busy clinical environments, how realistic is it to expect thorough skin assessments?
Well, it can be really challenging, but early recognition is crucial. Being able to accurately describe skin rather than just looking at it and saying, yeah, it looks okay, it really supports good handovers and timely intervention. We observe patients' skin every time that we perform a personal care task, and these assessments are valuable to that timely intervention.
Is there an assessment framework that can help staff remember the key elements of pressure ulcer prevention and, early identification?
Yeah, there is, and a really useful one is actually the asking framework. It's practical, it's easy to remember, and actually it focuses on prevention as much as identification. So asking stands for A for assessment of risk, S for skin inspection, S for surface, K for keep moving, I for incontinence, N for nutrition and hydration, and G for give information. It really reminds us to start with an assessment of risk, and that's using tools like Purpose T and clinical judgment. And then it's about inspecting the skin regularly, and not just during formal assessments, but during that everyday care that we spoke about earlier.
Sure.
We then think about the surface someone is sitting or lying on and whether it's providing enough pressure relief. Keep moving is really just about that repositioning and encouraging movement wherever possible, even small shifts in position. Incontinence management is crucial because moisture significantly increases the risk of that skin breakdown. Nutrition and hydration support, skin health and repair. And finally, giving information reminds us to involve the person and actually those that are really important to them, explaining risks and encouraging that shared decision making. So really, using asking helps staff take a consistent, person-centered approach and also reduces the risk of pressure damage through that early action rather than that reactive care.
Thank you. That is an incredibly in-depth assessment there.
Okay.
So let's move on to, pressure ulcers. What exactly is a pressure ulcer?
Right, well, a pressure ulcer is localized damage to the skin and or that underlying tissue. It usually occurs over a bony prominence, or it can actually be related to a medical device. It's caused by sustained pressure, often combined with that shear. The damage can present as an intact or an open ulcer, and it can be painful. So I really just want to highlight that we need to use the term pressure ulcer and actually not pressure sore or bed sore.
Okay.
So this really is in line with what was NHS improvements guidance of 2018, and it's ensuring consistency with national documentation, reporting and safeguarding. But also, I think it really does reflect accurate terminology.
Mm-hmm.
A pressure ulcer isn't always sore. When we get into those deeper layers of categories, individuals don't always feel pain.
Sure.
Also, bed sores. Pressure ulcers don't always occur in bed. They can develop from other surfaces and equipment.
Interesting, really interesting. And the damage doesn't always start at the surface?
That's right. So tissue damage can also begin below the skin, which means that what we see on the surface may underestimate what's actually happening underneath.
Okay, so what are some of the key risk factors that staff should be aware of?
Well, risk factors can often overlap. Reduced mobility, poor nutrition or hydration, incontinence, that reduced sensory perception. I spoke about those medical devices and also medical conditions which can affect blood flow.
Mm-hmm.
Smoking and actually previous pressure damage are all significant here. Previous pressure damage is particularly important because it permanently weakens the skin structure. I just want you to think of a brick wall here. So we've got a brick wall and it's got a hole in it. We want to repair this wall, but instead of putting bricks back in the hole, we actually use cement. So what happens over time is that the wind, the rain, that bad weather is going to continuously hit this wall. And that cement is going to start to dissolve. And what we're going to do, we're going to be left with that hole in the wall again. Now, I want you to think of skin here. And when skin heals, it heals with what we call granulation tissue. Now, that granulation tissue is only ever about 80% strength of our normal skin. So that's why we say that previous pressure damage is always going to be particularly vulnerable to that breakdown again.
That's an absolutely incredible analogy. So thinking about sort of the hospice sector and end of life, how does skin integrity change when someone is approaching the end of life?
I think that's a really crucial point there, Leanne. The skin is a living organ, and at the end of life, it can fail as in the same way that other vital organs can fail. So as the body deteriorates, blood flow is prioritized to the essential organs, such as the heart and the brain, to help maintain life.
Mm.
As a result, perfusion to the skin is reduced, leading to that decreased oxygen and nutrient supply. Even with good care, this reduced blood supply makes the skin far more vulnerable to breakdown and pressure damage. Understanding this actually can help staff recognise that not all pressure ulcers are avoidable and supports a compassionate, person-centred approach to care.
And what are there any red flag risk factors?
Yeah, absolutely. So these can include that rapid clinical deterioration, something that we call a long lie, after a fall. So a long lie really just refers to somebody who's been lying on the floor, so on that hard surface for over an hour.
Mhm.
New or increasing pain over a bony prominence. Skin that is hot, swollen, or discolored. And actually, I spoke earlier on about those medical devices in prolonged contact with the skin. These situations really require immediate action.
I mean, you've mentioned medical devices a couple of times. Device-related pressure ulcers seem to be increasingly recognised. Why do you think that is?
Yeah, absolutely. They really are. And it's because we're using more medical devices than ever before. And often many of these are rigid, and with that sustained pressure against the skin, you can see how the skin can break down. So we're looking at medical devices such as our oxygen tubing, our oxygen masks, catheters, that catheter tubing lying against somebody's skin, splints, and even compression devices can all cause damage if they're not monitored closely.
And what makes those more difficult to prevent?
Well, it works twofold because these devices are often essential for patient treatment. So we can't simply remove them.
Okay.
Prevention relies on regular skin checks, repositioning where possible, and actually using protective dressings.
And which areas of the body are sort of most at risk for this?
So really, any areas where we have a bony prominence. So areas such as the sacrum, heels, hips, elbows, ankles, and like we've just said, also those areas where those devices, those medical devices, might sit against the skin.
Okay, so let's talk about categorization. Why is getting this right really important?
Well, actually, first of all, I'm really glad that you've just used the word category there. Again, according to NHS improvements, we use the terminology categories now and not grades or stages. Again, this is to improve consistency. So accurate categorization guides management, communication, and reporting. It also has safeguarding and organizational implications.
Okay, so could you briefly talk us through the categories?
Yeah, absolutely. So category 1 involves intact skin with non-blanching erythema, which actually just means redness that does not fade when pressure is applied.
Okay.
But in darker skin tones, we're not going to see that redness. Instead, staff should be looking for changes such as discoloration, increased warmth, firmness, swelling, or pain. Category 1s are really early warning signs, and if we act at this stage, pressure damage is often preventable.
Okay.
Then we go on to our category 2s. Category 2 is what we call a partial thickness skin loss. And what we might see is this presenting as a shallow open wound with a red or pink wound bed, or we might actually see it as an intact or ruptured blister. I think if you think about getting yourself a new pair of shoes and wearing those shoes in, and you get that blister on the back of your foot, that's what we're talking about here. And we're talking about category 2 pressure ulcers, and we know how painful
Absolutely,
they can be. But what's really important is that category 2s are not used to describe skin tears, incontinence associated dermatitis, or other moisture related skin damage, as these have different causes, and actually they require really different management strategies.
Okay, and category 3, I assume, is the next.
It is, yes, it is indeed. So category 3 now involves that full thickness skin loss. So, we've gone through that top layer of skin, which is our epidermis. We've gone down through our second layer of skin, which is our dermis layer. And now we're sitting now in that subcutaneous layer. So this involves that full thickness skin loss. So like I've just said, where it extends through into that subcutaneous fat. And we might actually be seeing that subcutaneous fat, which is visible. We might have something called slough, which is present there. But bone, tendon, and muscle are not exposed at this category 3 stage.
Okay.
Now, we used to have something that we called unstageable pressure ulcers. And this is where the base of the wound was totally obscured by that slough or necrosis.
Okay.
So, in other words, we couldn't see the depth of the wound because it was obscured.
Okay.
So now what we are saying is that unstageable pressure ulcers should be categorized as category 3s.
Okay.
Okay. So at this stage with our category 3s, healing is slower and the risks of complications arises. Now, also just to point out, from our category 3 onwards, these are now reportable pressure ulcers
Okay.
to the Care Quality Commission.
Sure.
Okay. Then we're going on to what we call our category 4 pressure ulcers, and these are now the most severe of pressure ulcers, and they involve that full thickness tissue loss. So, like I said, we've gone through the epidermis, we've gone through the dermis layer, we've gone through that subcutaneous fat layer, and now we're sitting with exposed bone, tendon, or muscle. These wounds carry a very high risk of infection.
Sure.
Including sepsis, and they can be extremely distressing for that person. Management is complex and often requires specialist input.
Okay, so I understand that there's often some confusion around deep tissue injury. Is that something that we still categorise as a pressure ulcer?
Now that's a really good question. And actually, it's an area where practice has changed.
Okay.
We no longer class deep tissue injuries as pressure ulcer categories in their own right, but instead we are recognising them as pressure-related tissue damage.
Okay.
This is really reflecting our improved understanding that the damage often starts deep within the tissues before anything is actually visible on the surface.
Sure.
So at that point, it isn't always possible to say whether it's going to progress into an open pressure ulcer or not.
Mm-hmm.
So rather than prematurely labeling it as a pressure ulcer, the focus is now on careful assessment, close monitoring, and responding to any changes. And actually, this supports more accurate documentation and also helps avoid unnecessary escalation, particularly in people who are very unwell or approaching the end of life, where, like I said earlier, that skin failure and reduced blood flow can play a significant role.
Okay, so we've spent a lot of time talking about pressure ulcers when they're visible,
Yeah.
and categorization. So let's just focus a bit on prevention.
Yeah, well, that prevention, like when we looked at that asking framework, it really just includes that regular repositioning,
Sure.
the appropriate moving and handling, pressure relieving equipment, good nutrition and hydration, that continence care, and consistent skin assessment. It's those small, consistent actions that are going to make the big difference.
And ultimately, this links back to person-centered care, right?
Absolutely. Preventing pressure ulcers is about noticing the individual, responding early, and protecting comfort and dignity.
Thank you so much, Tracey. It's been fantastic to sit down with you today. I personally have learnt a lot having this conversation with you. As we finish, I'd like to encourage our listeners to reflect on one thing that perhaps you could do differently on your next shift to protect, your patient's skin integrity.
I think, every action counts, and the care that you're providing is truly going to make a difference.
Amazing. Thank you, and thanks for listening.
Thank you.